Okay, I'm sure everyone else will come on in when they're ready. Good evening, guys. My name is Michelle Goldsammler. I am a reproductive endocrinologist and infertility doctor at RMA New York on Long Island, and I'm happy to talk to you guys about egg freezing today, fertility preservation, egg freezing. Um, I am, of course, an OBGYN by trade and specializing in reproductive endocrinology and infertility. And so I'm fully capable of handling all fertility, hormonal issues, or anything else that anyone has. Happy to answer questions at the end as well. Feel free to put your questions in the Q&A box, and I'm definitely going to take a look there at the end of the webinar. And so I can answer your questions there. Or if you have any further questions, I'm going to have my contact information at the end as well. All right, so let's jump into it. So why are we talking about, fertility preservation? Why are we even talking about egg freezing? Well, we do know that, this is a trend that we've seen over the past, 20, 30 years or so, where there's more of a need to kind of talk about fertility preservation when previously this wasn't as much of a need for the community. And the reason for that is that women are delaying childbearing now. And part of that, or at least initially, one of the primary things that drove that concept is an increase in women in the workforce. And so women, were increasingly out of the home, increasingly having career pathways, which kind of change their onset about. Change their mindset kind of a little bit about when to start building their families. We know that peak fertility years in your 20s and your 30s dramatically coincides with those peak years of training and career advancement. And so by default, by that increase in workforce, women are starting to have children at older ages. And there are also some other societal pressures and other financial pressures that people have that also contribute to this phenomenon. We know that children are expensive, especially in our new environment now. Life is expensive. And so when you're in your 20s and your 30s, sometimes there's some concern about financial instability, not being able to afford children at that point. And there is a delay for some people for that reason. Some people are finding their partners in later reproductive years, and definitely kind of changes that shape of how many children people are having and when they start building their families. And some of this is also due to misinformation. So there's a lot of misinformation on the internet about how easy it is to get pregnant, especially in older ages. You hear about these women in their 50s and 60s getting pregnant. And so that kind of contributes to the misinformation that it's easy to get pregnant when you're older, or the thought that you could just use IVF when you get older and you'll have no issue building your family at that point. And so what I want to kind of suggest is that IVF is not the answer for all women in their late 30s and early 40s to get pregnant. It's a very useful tool. I use it all the time, and it's a great tool to help people build their families, but it's not as simply as doing IVF and having your child. And so, for those reasons, there's a concept of needing to preserve your fertility. And so, why do we need to do that? Why can't I just rely on IVF? Why can't I just wait until financially I'm stable and I have that relationship that I want, and I'm ready to have my family when I'm ready to have my family? And that's because nature, unfortunately, does not wait for us. And so we know that there's a natural decline in fertility as women get older. Women unfortunately have that biologic clock. We know that egg numbers decline, and they decline faster than we think that they should. Women have a set amount of time when they're able to get pregnant. And I just want to kind of point out to you guys what natural fertility really looks like for women. So our egg numbers are actually the highest that they've ever been when we were fetuses inside our mothers. And so we are born with all of the eggs that we are going to have. We don't make new eggs over our lifetime. We had about 6 to 7 million eggs when we were 20 weeks pregnant. By the time we're born, that number has already gone down to about 1 to 2 million. And that number dramatically declines again through our childhood until we hit puberty. When we hit puberty, we have a couple 100,000 eggs. And then we progressively lose eggs over our reproductive lifespan, where in fact we're probably only ovulating or have the ability to get pregnant with about 400 eggs in our entire reproductive lifetime, until there's that slow progression to menopause, where you have approximately about 1,000 eggs at the time that menopause occurs, and then that number rapidly declines as well. And so I'm a very visual person, just to kind of show it to you, here in just a very similar fashion. Again, there is that significant decline already, even before that we are born. There's a significant decline to about 1 to 2 million eggs. We can have about that 400,000 approximate eggs at puberty. By the time we hit age 37, that number significantly declines about 25,000 eggs. And these again are estimates and approximates. They're not 100% for every single person has the same number. But like I mentioned, at that average age of menopause, at age 51, we have probably about 1,000 eggs left and then very rapidly decline. And so the question is, how are these eggs lost? Well, we're born with all of them, but they are microscopic and in storage in our ovaries. And it's estimated that we lose probably approximately 1,000 microscopic eggs each menstrual cycle. But from that group of 1,000 microscopic eggs, a smaller group of them, a smaller cohort of them, grow just enough that I can actually see those on ultrasound. And those are your group of potential eggs for that month. From that group of potential eggs, one egg becomes a dominant egg and ovulates and tries to get you pregnant. And the other small potential eggs will kind of linger for a little bit, but then undergo a natural process of atresia where they disappear essentially. And so by the time you get your next period, about 2 weeks after ovulation, that group of potential eggs for that cycle has all disappeared. And your cycle resets when you have your period. It's a different group of potential eggs from the eggs that you have in storage in your ovary. It's a different group of potential eggs that are trying to grow that month. And so every month that we get a menstrual cycle, we're losing a group of eggs. Now that shows us the natural fertility decline in terms of numbers. We know that it's kind of a slow decline until we hit about our mid 30s and then starts to go down faster. And I'm going to explain that again a little bit more as well in a little bit. But we do know that the egg number goes down as we get older. There's also a concept of egg quality changing as well. Egg quality matters significantly. I would even venture to say sometimes even more so than egg number. Now, the data that I'm showing here on this slide is actually data based on quality of embryos. And when I'm talking about quality, I'm really talking about genetics or genetic abnormalities that we can find in eggs or embryos. That's something called aneuploidy, which is an abnormal chromosome number. Eggs have half of the genetic material a person has. Sperm has half the genetic material that a person will end up having. The two combine to make an embryo. The egg and sperm have to fertilize to make an embryo. And in total, they have 46 chromosomes. They have the right amount of genetic material there. Now, we do know that as women get older, more of those embryos have genetic abnormalities in them, most likely coming from abnormal eggs, but not always. And so there's data about testing that we can do at the embryo stage to look at the genetics of those embryos to make sure that when egg and sperm combined, that it created the right amount of genetic material. And we can see aneuploidy or abnormal chromosome numbers, like missing a whole chromosome, have an extra chromosome, things like that we can see. And we know based on data that there is a change in the embryo quality very significantly linked to the maternal age of the eggs. So the age of the mother and therefore the age of the eggs is really what's driving the abnormal embryos. And so we know at age 30, a portion of your embryos are going to be genetically abnormal. But as you can see, from age 30 to age 35 to age 40 to age 45, the rates of abnormalities in embryos are climbing. They're rising significantly. Now, this data is based on embryos, but again, it's presumed to be based on eggs and abnormality in egg because it is so strongly linked to the maternal age. The paternal age, the age of the sperm, does not impact the rate of abnormality. So we know that it's coming from the eggs. But it's actually thought to be that the numbers you see here are lower than what we expect for eggs themselves. The abnormality rates in eggs are higher than what you see here because sometimes an abnormal egg can't even make it to this stage where they're able to do the genetic testing. Sometimes an abnormal egg just can't even mix with sperm. And so it doesn't even make an embryo that could even be tested for genetic testing. And so it's presumed that the chromosome abnormality rates or the aneuploidy rates in eggs for each of these ages is actually higher than what you're seeing here on this data. Oops. And so again, I'm a very visual learner just to kind of show you what does that mean? What do these abnormality rates in eggs or in embryos mean? Well, it's showing us that as the maternal age rises, as women get older, the aneuploidy rates in their embryos, the abnormality rates in their embryos rise. And as a result, the ability to get pregnant declines. This red line is the live birth rate or the ability to have a live birth. And you can see here that it's kind of a decline as women get older. There is a tipping point that happens at age 37. You can see that the rate of abnormalities, the slope of this line changes kind of at age 37. And then again at age 40, here you also see another drop off, another decline as well. The reason why we care is that abnormal chromosomes is actually one of the most common reasons for miscarriage in the first trimester. And so you see in parallel to the aneuploidy rate that you see here, you see a similar climb in miscarriage rate as women get older. So it's harder to get pregnant as we get older and much more likely to end up in a miscarriage. And so this egg quality issue is one of the, and egg number issue, so a declining egg number and a declining egg quality as we get older, is what's really driving the importance of considering preserving your fertility before you get to those tipping points. So that when you are ready to build your family, when you're financially secure, when your job allows for it, when you find the right person to build your family with, that you do have the strategy and means to be able to do so. And so if we are talking about preserving our fertility, what options do I have? Well, we can freeze eggs, which is what we're going to be talking about today. We could also freeze embryos. So if you had a particular sperm source that you knew you were going to use, you have a partner already, but you guys just aren't ready to build your family yet, we could take your eggs, take the sperm, create those embryos, see what fertilizes, see what develops. We could even do the genetic testing of those embryos and then freeze those for you for the future. But for many people, they don't know what sperm they're going to use, and therefore a very, very good option is freezing eggs. So who should freeze their eggs? Well, anyone who you know may want or needs to delay childbearing. Again, if you know who your sperm source is going to be, then you can consider freezing embryos as well. If you don't know who your sperm source is going to be, then we're talking about freezing eggs. So that kind of leaves options open for sperm in the future. But there are other people that don't do this for societal or more elective kind of reasons. There are people that preserve their eggs or preserve their fertility because of a medical need, whether they were diagnosed with cancer and are undergoing treatment that's toxic to the eggs and the ovary, like chemotherapy, or need surgery that may kind of impact their egg number or ability to conceive in the future. There's also some women who have difficulty for either ethical or religious reasons of storing embryos, but they would feel more comfortable storing them at that egg stage. stage. That's a small subset of people, but also another potential reason why you may be freezing eggs instead of freezing embryos or using them right away. And so the big question that I have is, yes, we've decided we want to freeze our eggs. Well, how many eggs should I freeze? And so the answer to that question is very dependent on your age, how many kids you want to have, and a little bit about some of what your egg potential looks like. And so I'm going to kind of explain where our estimates come from. And so there's no hard or fast rule that says what specific magic number of eggs that you have frozen is going to guarantee that you have a pregnancy. We do like to estimate for women less than 35 years old, a rough estimate is about 10 to 15 eggs per pregnancy that you want to have. Now, that may seem like a high number, but I'm going to explain why. And so this visually can kind of show it to you. Not every egg is going to yield a pregnancy. When we freeze the eggs, what has to happen is that in the future, first of all, they need to thaw. Thaw rates are pretty good for eggs. Thaw rates for eggs is probably somewhere between 90 and 95%, which means in a group of 10 eggs, sometimes or many of the time, 10 out of 10 will thaw successfully. Sometimes one might not thaw successfully from that group of 10. And so that's not really where we're too worried about those eggs. But we know that not every egg, even if it's a normal egg, not every egg is going to fertilize with sperm in the future. Now, if you're under 35 and we assist with that fertilization, which we do for frozen eggs, about 80% of them will fertilize. And so from a group of 10 eggs, like you see here, it's not unexpected to have 8 of them fertilize. Now, not every fertilized embryo is going to develop properly into that embryo stage where it's ready to be put back into the uterus. And roughly 50% of embryos that fertilize will develop properly in the lab when you're less than 35 years old. And so from a group of 10 eggs, I would estimate 3 to 4 embryos are most likely going to be produced. And then from there, you have to take into account that aneuploidy rate, where we do know that some of these embryos are going to be genetically abnormal. And so I would say of that group of 3 to 4 embryos, it's possible that 1 or 2 of them are going to be genetically abnormal. And so really those 10 eggs is really just giving you 1 or 2 potential embryos that are potentially genetically normal in order to get pregnant from. Now, each genetically normal embryo has a very good chance of getting you pregnant, but it's not guaranteed. And so that's why these are rough estimates. And I like to err on the side of caution and say, well, if we could get a little bit more in storage, it puts us in a better position. Now, if you're a little bit older, we know those egg abnormality rates play more of a role here. And so we don't see as good fertilization for women that are over the age of 35. That fertilization rate might be 60%. And those embryos, some of them are genetically abnormal and won't develop properly. It may be not 50% blast rate, 50% embryo development rate. It may be closer to about 30%. And so that same group of 10 eggs that you have frozen yields fewer embryos. And that's why the chance of getting pregnant for one pregnancy from that group of 10 potential eggs is probably less. Looking at this a different way, these are showing you how many eggs you have frozen, the number of eggs you have frozen, what's the chance of you having one baby. And each of these curves is a different age. So this top curve here, which shows that you need fewer eggs to have a good chance of having a pregnancy, these are your egg donors. When we talk about people that donate their eggs for other people to get pregnant, these are your young 20-year-olds that have no issues. Similar to our less than 35-year-old line. So at about 10 eggs here, it's probably about a 70% chance of getting pregnant with that group of 10 eggs frozen. But if that number went up to 20, if for some reason you were able to freeze 20 eggs less than the age of 35, your chance of having one baby from that group of 20 eggs is quite high at about like 90%-ish or so, which is Very, very good odds. You can see similarly if you are 40, which is this middle darker red line. I'm not sure if you could see my pointer. So I'm going to just try to point it here. Sorry, this middle red line over here. You see at 10 eggs, it's only about a 30-ish% chance of getting pregnant. And at 20 eggs, you're probably closer to that 50% chance of getting pregnant. And that's really, again, reflective of egg quality issues as we get older. All right. And so just to kind of, again, show you visually, oops, give me 1 second here, just having a slight snag there. All right. And so if you look here again, I'm again a very visual person. So at 10 eggs that you have here, if you're 30 or 35, it's about a 70% chance of getting pregnant. By the time you hit 37, like I mentioned, 37 is one of those tipping points. Chance of getting pregnant with those 10 eggs is about 50%. And then by the time you hit 40 and are freezing eggs at the age of 40, the chance of getting pregnant with 10 eggs that are frozen is about 30% there. So how does egg freezing work? You want to freeze a group of eggs, you decide you're going to try to do it as early as possible. How does it work? So there's a technical answer of how we do egg freezing and a clinical answer of what does that mean for you to do an egg freezing cycle. So the technical answer is that we freeze your eggs, but it's not like taking an egg and putting it in a freezer. It used to be about 20, a little bit more than 20 years ago, we did a process called slow freezing, where we took an egg and slowly kind of reduced the temperature of that egg until it got to the point where it was frozen and could be put, in deep, deep freeze. But we found that with that slow freezing process, the eggs were had some compromise to them because eggs are really filled with a lot of water. It has a lot of water content in an egg. And so if you freeze them too slowly, ice crystals can form in the egg, and there's damage that can actually happen within the egg itself. And so about 20 years ago, there was a new process where we do fast freezing, or it's called vitrification, where we're able to freeze the eggs very, very quickly, going from like 37 degrees to negative 100, 200 degrees Celsius, we're talking, in like a second. And so that plus some other techniques in the lab were able to create a process that kind of protected that egg from like ice crystals forming and harmful things happening to them. And so that's been in use probably for about the past 20 years. And about 12 to 13 years ago, once we've proven that that was safe for eggs, egg freezing is no longer considered experimental for the past 12 to 13 years or so. I think since 2013, I think, was no longer considered experimental. And so very safe to do this with the eggs. But that's just the technical piece in the lab. What you guys really want to know is, what does that mean for you? How does an egg freezing cycle work clinically? And so the way an egg freezing cycle works is there's some testing and there's some evaluation that we have to do. There's a growing egg phase. There's a process to retrieve the eggs, where we're able to extract that group of eggs. Then we have to freeze those eggs. And then we kind of make sure that you're doing well after the procedure. And so those are my little pictures that didn't pop up before. All right. And so the evaluation is that first step. And so what does that evaluation entail? Well, it entails something called ovarian reserve testing. I want to take a look to see what your individualized egg potential looks like. I want to see how old you are. I want to see what do I estimate I'm going to be able to grow for you for one cycle's worth of trying, for 1 month's worth of trying. And so part of that evaluation is an ultrasound and some blood work. The ultrasound makes use of the fact that we're able to see those small potential eggs that you have that month. Remember, we discussed that a small group of eggs grow just enough that you can see them on ultrasound. And then from there, you have one dominant egg grow and ovulate. Well, if I take a look at an ultrasound, it kind of looks like the picture here. You see these little dark circles. These are fluid-filled spaces called follicles. I think they look like a chocolate chip cookie. Like the chips of the chocolate chip cookie are your eggs, they're your potential eggs. In each of these fluid-filled spaces should be a microscopic egg. Now, normally they don't all grow that month. Normally only one dominant egg grows, and I'm going to show that to you. But what we're trying to see is if we can encourage this ovary to grow more than one egg, how many eggs do I think I can grow in 1 month of trying? So this ultrasound is used in combination, excuse me, in combination with some hormones that we check in the blood work. Some of them are done right when your cycle resets, when you have your period, and some of them can be done at any point in time in your cycle. And that's a blood work that's kind of listed here. Excuse me 1 second. So the timing of what an egg freezing cycle looks like makes use of what a typical menstrual cycle timing looks like. And so if you had a 28-day cycle, I know that when your cycle resets on day 1 of your period, you have those small potential eggs. And naturally, one of those small potential eggs is going to grow. It's going to take about 2 weeks to grow that one natural dominant egg. And around day 14 of your cycle is typically when someone will release that egg and ovulate it for that typical 28-day cycle. If your cycle is not 28 days, then the day of this ovulation is going to be adjusted based on your cycle length. And the time it takes for you to grow that dominant egg before you ovulate is actually what varies from person to person. Once you release that egg tries to get you pregnant. And so over the next 2 weeks, there's some hormone changes that kind of help potentially support an early pregnancy if there is a pregnancy. And then at that 2 week mark, when there is no pregnancy, your body resets, you get your next period, the cycle starts again. And so that one dominant egg, I can see on ultrasound. So if I did an ultrasound for you midway through your cycle, right before you ovulate, you can see the little small potential eggs that were there before, but now one of them is much bigger than the others. This egg was naturally selected to be the egg to ovulate this month, and this egg will be the one that ovulates. Now, what causes that to happen? Well, it's our hormones. I'm the hormone doctor. It's always related to hormones. And so the two hormones that kind of help with that beginning process to help grow that egg and help that egg ovulate are a hormone called FSH, follicle stimulating hormone, and LH. Now, the follicle stimulating hormone helps the follicle or the egg grow, stimulate and grow. And LH helps that egg mature and then helps with that last piece of ovulation. And so we as reproductive endocrinologists and fertility doctors make use of this natural cycle to be able to help you grow more than one egg. And so how do we grow multiple eggs? Well, we give you back extra FSH and LH. We give you back those same hormones that your body's making to grow one egg. We give you back more of them to try to grow as many of those small potential eggs as we can. And so these medications, unfortunately, are injectable medications, and we give them to you for the same time it takes you to grow an egg and ovulate naturally. It's the same 2 weeks that you're taking these medications to grow a group of eggs. And so you take the medications, and these small potential eggs hopefully become multiple large dominant eggs and over that 2 week period of time. Now, we monitor you during those 2 weeks very closely, usually every 2 to 3 days, where we do ultrasounds like this so we can see how many eggs are growing, see what size those eggs are. And we also do hormonal blood work to kind of make sure that the hormones look like they're rising appropriately, make sure everything is progressing as we expect during the cycle. And when you get to a stage where a group of these eggs look like they're the right size, that they're ready to be mature and ovulate, then we progress to the egg extraction piece, being able to remove this group of eggs from the body. And so we actually time ovulation for you. We need those eggs to finalize that maturation process. And so we time when that's going to happen. We know exactly when you're going to ovulate. We have you take a medication that forces your body to ovulate at a very specific time. And we use that timing to time 36 hours later a procedure to extract that group of eggs from the body. That procedure is called an egg retrieval procedure or an oocyte retrieval procedure. That egg retrieval procedure uses the same ultrasound that we've been using to monitor the eggs to kind of see that we're having those big follicles grow. We use the same ultrasound to look at those follicles while you are undergoing the procedure. And we use that ultrasound to guide a needle into those dark circles, into that fluid-filled space, so we can extract that fluid. And we hand the fluid to the embryologist who works with us at the time of the egg retrieval to actually look under the microscope to see, was there an egg inside that follicle that was growing? And so they're looking for those microscopic eggs inside each of the vials of fluid that we extract from the ovary. Now, the egg retrieval procedure is done under anesthesia, so you are comfortable for that procedure, but it's IV sedation anesthesia, meaning that you are breathing on your own. You do not have an endotracheal tube down your throat. You get an IV place, you get some medication through the IV. You are asleep, you're comfortable, but you're not aware that we're having the procedure done. It's very quick. It takes about 15-20 minutes. It is ultrasound guided. The ultrasound is a vaginal ultrasound, so everything is done through the vagina. There are no cuts or incisions on the belly that need to heal afterwards. And typically, after an egg retrieval procedure, most people recover from that and are able to go back to work the next day. Obviously, it's an anesthesia-based procedure, so someone brings you home from that procedure that day. There's a little bit of cramping after this procedure. Your ovaries are enlarged. There's some bloating associated with it, but typically the symptoms are mild and manageable, and most people will actually feel back to themselves by the time they get their period after an egg retrieval, which happens about a week and a half after the egg retrieval. Most people, again, are able to go back to their regular activities and work the next day. And so you're really only taking off of work for the day of the egg retrieval itself. Now, just to kind of give you an overview look of what that calendar really looks like, kind of putting it together for you, an egg freezing cycle for the vast majority of patients, once you're ready to start the process, really should take about 2 weeks, sometimes 2.5 weeks. It starts with your period. You come into the office to do that initial ultrasound to look how many potential eggs you have. You do the baseline blood work to make sure that your hormones look like you're ready to start a cycle, that you're at your baseline, you're ready to grow a group of eggs. You then start those injectable medications, that FSH and LH hormone, to grow a group of eggs. That stimulation, that egg growth, typically happens for 8 to 12 days, depending on how quickly you grow a group of eggs. And during that time, you're doing the monitoring every 2 to 3 days. Monitoring in our offices happen early in the morning. So you come in, get your ultrasound and blood work, and then go about the rest of your day, go out to work. We do monitoring starting as early as 6:30 in the morning so that it's not disruptive to your schedule, to your daily life. And so again, a little bit less than 2 weeks of the stimulation, you then trigger for ovulation and 36 hours later have your egg retrieval. The reason I added this up to 5 weeks is because sometimes in a select group of patients, we actually like to put you on birth control pills for about 2 to 3 weeks before you start the egg growing phase. There's a variety of reasons why we do that for a select group of patients, and it's very patient dependent. And so that would be something that you would talk to your individualized physician about, what type of protocol. But at most, we're talking the 2 to 3 weeks of those birth control pills, and then about the 2 weeks of the stimulation leading up to the egg retrieval. Now, the day after the egg retrieval, you find out how many of the eggs that we were able to extract are actually mature. And only mature eggs are able to be used later, so only mature eggs are frozen. And so you'll get a call from us the day after your egg retrieval letting you know how many eggs we were able to freeze for you. And so the big question that people have at that point is, well, how long can my eggs stay in storage for? And so the actual length of time that the eggs are in storage is not typically thought to impact the quality of those eggs. Once they're in storage, they can stay in storage indefinitely. The times where those eggs are the most vulnerable is that initial freeze, again, putting them under those temperature changes initially, the freeze process, and the thaw process. Now, again, over time, as techniques have gotten much better, the thaw success rate, again, is 95% of your eggs are going to thaw successfully. And so the number of eggs that you typically have in storage is a good predictor of what realistically you're going to have in the future to be able to be used. All right. Um, and I think that is where I stopped this educational webinar. But of course, I'm happy to answer any questions that anyone has. I am going to just make sure that I can see everyone here and see if anyone had any questions for me. Let me just take a look in the Q&A here. And so, oh, I have a question here. Okay, so someone had a question about doing this process if you're already on a birth control pill or on other contraception like an IUD. So the interesting piece about this is that an IUD, whether it's a non-hormonal IUD or a hormonal IUD, a progesterone IUD, actually will not interfere with this process at all. I do an egg freezing process where I'm growing a group of eggs with that IUD in place. We leave it there, no disruption, does not interfere with the growth of an egg or anything like that. And it helps keep you protected from unwanted pregnancies during that time. For a birth control pill, most people will either just have you withdraw from that pill and go right into an egg freezing cycle. And so, as if you were doing a birth control pill protocol anyway. On rare occasions, if someone has been on long term birth control pills, the ovaries are a little bit on the quieter side. They're a little suppressed. And so sometimes, and that's very patient dependent, sometimes we may have you come off of your pills for about one cycle's worth to kind of perk those ovaries up a little bit so they're able to grow a group of eggs in a more predictable way and not be as suppressed. But that's rare. Most of the time, we're able to go right into a cycle being on a birth control pill. And then once you get your period after the egg retrieval, you can go right back to your other form of contraception. I have another question about the IUD and kind of follow up for the IUD. If the IUD reduces my period duration or skips periods, does that change things? Doesn't matter if it reduces the timeline for your bleeding. What matters is using the bleed just to kind of indicate for us when the cycle reset for the ovary. And then if you skip periods with it, the only difference is that if you don't have bleeding, we're not going to know exactly when your period starts. And so for my patients who have an IUD in place who don't get periods on their IUD or just get spotting, what I do is I just bring you in for an ultrasound and blood work so I can look at your ovaries and I can see, well, are they all small? Do you have a big dominant egg that's trying to ovulate? And I do a set of blood work so I can actually predict where you are in your cycle and I can time when is the appropriate timing to start a cycle. And so we have means to do that. All right, we have a question about, can you please talk more about selecting a facility and the insurance and pricing side of things? Okay, so that's a very good question. I would say the vast majority of REI centers are able to do an egg freezing cycle for you. It is the same stimulation process that we do IVF. And so if they have a good embryology lab and they are doing a good volume of cycles a year, there's not a significant difference in the technical piece of doing an egg freezing cycle and an IVF stimulation cycle. The one question that is very facility specific is storage of your eggs once they are retrieved. Are they going to be stored on site? There are also long-term storage facilities where you can always transfer your eggs to a long-term storage facility and leave them there if that's your desire, and then move them back to whatever lab you choose to use for your treatment. Pricing is very variable. Many insurances do not cover elective egg freezing. Some insurances are getting much better about covering egg freezing for medically necessary indications, such as fertility preservation before cancer or before reproductive altering treatments. So sometimes we've had good success if you need to take a toxic medication that's going to harm your ovaries, even without the diagnosis of cancer. Sometimes insurances will then cover egg freezing, but that's very insurance specific, and they change their policies on a year-to-year basis. And so definitely talk to your benefits person for your insurance. And then whenever you come and see an REI, we also do a financial check for your insurance and let you know if there are costs associated with an egg freezing cycle or any treatment in the office. Someone had a question about what's the maximum age for egg freezing and can we see right away if the egg has abnormalities? Good question. It's advised to freeze your eggs earlier rather than later. I typically don't recommend egg freezing for women over the age of 40, just because the abnormality rates in those eggs are very high. But, you know, there are some national guidelines that say maybe even under the age of 38 is preferred for egg freezing. There are certain circumstances where you weren't able to freeze your eggs before age 38, and definitely on a one-to-one basis with your doctor, they may still go ahead and freeze eggs for you depending on your circumstance, with the acknowledgement about how many eggs you really need to have in storage to have a realistic chance of having a pregnancy. Unfortunately, we can't diagnose abnormalities in eggs at the egg stage. The technology that we have is only at the embryo stage, which is why I kind of showed you that progression of how many eggs do we really need to have for that estimate of how many embryos are we going to be able to produce. That's the big question mark that's there with egg freezing. And so if you do know what sperm you want to use to build your family, then you might choose to do embryo freezing, because then you can do the genetic testing at that point and truly know what you have in storage that might be usable in the future. All right, there was another question here. What percentage of eggs are usually able to be used after the freeze-thaw process? If 10 eggs are retrieved, how many of them will survive the freeze and thaw process? So like I mentioned before, thaw rates are probably about 90 to 95% of a group of 10 eggs. I expect the vast majority of the time, all 10 of them will thaw. Every once in a while, maybe 9 out of 10 will survive the thaw, but in many, many cases, actually 10 out of 10 would survive that thaw. What else? Anyone else have any other questions for me? All right, guys. Again, if you have any additional questions, feel free to reach out to me. Feel free to call. You can always make a consultation. I'm always happy to just talk it through to see if this is the right choice for you or not. It was a pleasure speaking to you all, and I hope everybody has a great evening. Take care. Be well.